Hello again, folks. This slide set will be focused on depression in our first of three modules about common behavioral health problems that we'll see in primary care. And as usual, the focus is on primary care, knowing full well that those of you who are going into the psychiatric nurse practitioner track will have much more depth about all of these topics. It's important, though, because in primary care, experts estimate anywhere from 20 to 60% of our caseload is actually mental health problems or behavioral health problems, if you will. I would say it's probably on the higher end, especially when you consider somatic complaints like chronic pain and fatigue. Here are our objectives. We're going to focus again on this slide set on depression. And our medications that we'll be touching upon throughout the lesson. This is only a representative list, by no means exhaustive. Once again, we're back at the neurotransmitters. Just like last lesson, they're very important, as we know, in terms of brain function and in terms of mood and ability to handle stress, etc. Our neurotransmitters play a key role. The usual suspects in terms of depression and anxiety that we kind of target with the drugs that we know at this time are only three of the very, very many neurotransmitters that have to do with mood and with our mental status and mental health. Those being serotonin, norepinephrine, and dopamine. So again, very focused, although very limited, and we know that there are many, many more neurotransmitters in our brain. This is not, of course, an assessment, but I like to just touch upon the fact that in primary care, we do use a couple of tools, particularly the PHQ-2 and PHQ-9, to take a look at depression screening using the 2, and then the 9 for further screening, as well as targeting symptoms. Remember, going back to the DSM criteria regarding major depressive disorder, we have to have the disease present or the symptoms present for 2 weeks at a time altogether, and 2 or more weeks ongoing. As well, 5 symptoms have to be present. Now, the PHQ-2 focuses on 2 symptoms that must be present in order for depression to be diagnosed or major depressive disorder to be diagnosed. And those are depressed mood and loss of interest in activities that normally are found pleasurable. Now, if the PHQ-2 is positive, either one or both questions is answered to the positive, we ask the patient to complete a PHQ-9. I'm not going to click on these links, but I think it would be helpful for you to do so, so that you understand what it is, the target symptoms that we're looking at. Now, the target symptoms can be what we call vegetative symptoms, those where the patient is feeling down, depressed, can't motivate, they're sleeping a lot, and so forth. Or they can be other agitative symptoms, anger, unable to sleep, having trouble with mood and angry outbursts, etc. Food and eating are also part of the symptom profile. I like to track the symptoms for the patient because I ask them to think about how the medication or the treatments that we're prescribing might affect some of the symptoms that they're having, and I have them repeat the PHQ-9 at each visit so I can have a feel for how they're progressing or not progressing with the use of whatever medication or treatments we've prescribed. Just a side note, there is the copyright on the PHQ tools is Pfizer, but it has been validated, and I do give you this link for an article that you can look at that shows that it is a validated tool. Now, I want to remember and remind you that at every visit, we always ask about suicidality and homicidality directly to the patient. I like to ask this every time. It's important. It will not bring on suicidality, and it is critically important to understand because that's a life-threatening emergency, and patients must be referred immediately for urgent care if they do have an actual method and plan in place. What about bipolar disorder? This is a great tool that, again, I'm not going to link out to at this time, but it gives us a kind of a snapshot of the multiple symptoms that the patient may be experiencing that may have related to depression. And bipolar, of course, the key symptoms there are the mania symptoms, where they're patients unable to sleep, they stay awake for days at a time, they take on, and then secondly, taking on multiple projects or new ideas, or spending money in kind of new ways that they can't afford. Very important, because we are often the people who identify in primary care that a person does have a bipolar disorder, or a new episode of mania or hypomania, and that may be triggered actually by our prescribing of an antidepressant medication, an SSRI or an SNRI. So we are very, very careful that if that happens, we gradually get the medication taken away, and we refer them for further evaluation and appropriate treatment. That's not to say, by the way, that people with bipolar disorder are not on classic antidepressive therapy as well, and you will see that out there. But there is that caution that we want to be careful when we're prescribing those medications in primary care, that we don't trigger a mania episode. Major depressive disorder, again, whether or not we're underdiagnosing it, some may argue, or we're overtreating it, particularly with drugs, especially in younger people, there are arguments about that. Really important to think about non-pharmacologic treatment. Again, like I mentioned in class and in the Journal Club number 2, that weird thread that you all were talking about of things that are not drugs at all, and talking about it in a pharmacology class or a pharmacotherapeutic class, it's really important, because these are the more effective and very effective therapies that we can offer patients, whether it's psychotherapy, cognitive behavioral therapy in terms of the therapies, which are non-medication, combined with medication or without, or whether we're looking at alternative treatments such as meditation, acupuncture, and those having great benefit for these patients. Exercise, especially aerobic or endurance exercise like walking, has great evidence to support its use in both reducing depressive mood as well as increasing endorphins. Nutrition as well, and there are many, many approaches to this. I like to kind of stick to kind of clean eating, encouraging people to get away from processed foods, away from sugars, etc. And even those small steps can help persons just improve their overall mood and well-being. Effectiveness of the medications is important to consider. The book talks about 60 to 70% effectiveness of the kind of core medications, particularly SSRIs, SNRIs. And I have seen that in practice. About 3/4 of the people will have benefit. Of course, we have to weigh the risks and the benefits of these medications. Now, the categories in the table in your text. The textbook really has, I like the table. It's really helpful. It's a great study tool for you to look at these drugs in terms of the classifications, the side effect profiles, the adverse reactions, etc. I would say it's kind of a great go-to, and as well as your other drug resources to look at these medications. SSRIs being kind of first line for most of us in primary care, mostly because there are 4 medications in that class on the $4 list, and that kind of makes it the go-to for most of us. They've been around the longest and have been tested. SNRIs are great too. We don't have any of those in an inexpensive form at this time. Serotonin and norepinephrine reuptake inhibitors. Again, these drugs, both SSNRs and SNRIs, work by inhibiting the reuptake, which you remember from one of the videos is important, of serotonin, and we like that serotonin and norepinephrine to be available. Tetracyclics not frequently used. I'm going to skip down to the bupropion, which is in that miscellaneous category. Great drug for a lot of reasons. hits on tobacco cessation, kind of a 2 minutes in one drug. Not used as much. It is now on the lower price list on some of the drugstores, so that's helpful. Tricyclic antidepressives, old drug, high side effect profile, especially with the anticholinergic effects, and very high risk for suicidality. It's a very toxic drug in fairly small doses, so it's got to be used in great caution there. But in low doses, again, it's a good 2-for-1 for migraine as well as sleep. So sometimes people respond to that. MOA inhibitors, rarely used. I do not prescribe in primary care, but they are a great drug for some people who just don't get effect from the others. They have severe dietary restrictions as well as interaction profile that's phenomenal. So we stay away from that in my kind of practice. So we want to look, when we think about prescribing, I like to think of half-life spectrum, short to long and in between. I like short half-lives for older patients, patients who may be more frail, more prone to side effect, because we can get them off the trip more quickly. Long-acting medications. So our longer half-life drugs, like fluoxetine, I kind of like that for some of my folks who might forget to take their medication. Because withdrawing off these SSRIs, particularly SNRIs, if they have a short half-life, it's great. Like I said, we can get them off of it quickly, but withdrawing abruptly, if they forget to take medication for a day or two, is very uncomfortable. It's not life-threatening, but very uncomfortable, like a flu-like syndrome. Also want to look at whether it's stimulating or sedating. We'll do that next. And whether there's indication for coexisting things. As always, can we take advantage of anything in terms of dual effect? And of course, we want to target various transmitters. This is a nice little summary slide, kind of takes the various commonly used medications and puts them out in terms of sedating versus energizing. Our neutral drugs are kind of nice because they really don't have a strong effect either way. But say we want someone to have better sleep, so we might try them on paroxetine versus fluoxetine, particularly. This is just a little side thing you can look at yourself, talking about specifics of the serotonin receptor sites. And of particular interest to me is the bottom one, the ondansetron, which is actually an anti-nausea drug, but it works on a serotonin receptor site. Kind of interesting. Oh yes, I know, it's a pun, the downside, so to speak. Common side effects, as always, we want to say what's going to make the patient stop the med, and adverse reactions. Oh, excuse me. I just got a phone call. I'm just going to take right here. Oh, hi, Scott. Yeah, how are we doing? How's the medication treating you? Yeah. You've been taking it for a couple of weeks, and so you're feeling better, huh? A little less depression. Good. Sleeping a little better. Good. And that nausea you talked about last week when I checked in, that's going away. Good. So you just taking like a little food with it, and that's going well. Good. Yeah, that was the sertraline we have you on. Okay. Oh, yeah. Oh, I know. It is pretty common, as we talked about at your visit. Yep. No, you're welcome. I'm glad we brought it up too. But with your girlfriend now, you're really concerned about the sexual side effects, having troubles with that. Okay. All right. Scott, are you still smoking? I know you talked about wanting to quit, but having a hard time with that. Okay. Why don't we switch you over to a medication called bupropion? It's also inexpensive, and we can help you with that, as well as continue with the antidepressant effect. It's a little less bothersome in that way. Okay, and you got to go. Okay, all right, I'll call that in. Talk to you in 2 weeks. Thanks. So, of course, we know it's going to take a couple of weeks for the medication to really work well for him, so we want to give him a couple of weeks on that. We do want to be careful of serotonin syndrome. Serotonin syndrome is life-threatening and characterized by high blood pressure and rapid heart rate. I'm going to pause here, and we'll continue on the next slide set.